Hi, my name is Mariana Hensley. I work with Catholic Relief Services in India as Program Quality Manager for Health, and I'd like to share with you some of the lessons that we're learning about developing mobile content for clients. The ReMiND pilot project is a 3-year initiative implemented by CRS in partnership with Dimagi Incorporated in Vatsalya. The project is implemented in Kaushambi district in the Indian state of Uttar Pradesh. CRS and its partners are working with government community health workers, called ASHA, to improve the quality of community-based care and support for women and children. The primary behavioral changes being addressed by the project are increased utilization of antenatal and delivery services and improved health and nutrition practices during the prenatal and postpartum and newborn periods. But as the ReMiND project evolves, the scope of intervention is expanding to target other key behaviors, such as routine immunization, that the government of Uttar Pradesh has prioritized during the first 1,000 days of life. So why mobile content? The decision to develop mobile content for what has become the ReMiND pilot project was a combination of strategic choice and serendipity. Based on some early mHealth work in Uttar Pradesh, CRS made the decision in late 2010 to begin design of an mHealth project that would address maternal, newborn, and child health in one of the state's poorer performing districts. At almost the same time that CRS made the decision to pursue mHealth programming in Kaushambi district, Dimagi launched a call for development partners in India who would be interested in participating in a beta test of its ComCare software using or adapting an existing pregnancy checklist. The timing of this opportunity and complementarity of CRS and Dimagi's vision for using mobile technology to improve maternal, newborn, and child health led to an early partnership that has helped to drive ReMiND's mobile content development and innovation. Another early factor that figured into the decision of not only why, but how mobile content would be developed was related to phone ownership. Assessments revealed that while the majority of households in Kaushambi district had mobile phones, it was most often kept by the man, or the male head of household. Women's limited or inconsistent access to mobile phones led the project to look for another way to reach pregnant and lactating women. The government community health workers, or ASHA's, responsibility to conduct pregnancy and postpartum home visits for counseling and treatment of newborn sepsis provides an opportunity and an alternative platform for reaching women with targeted mobile content. Low literacy rates, especially among women, also contributed to the decision to focus on development of mobile content that combined still images and audio rather than SMS-based systems. So our final decision was to develop multimedia content that would be used by ASHAs equipped with basic feature phones operating ComCare-based job aids. With the help of audio and visual prompts from the mobile phone, ASHA are supported to systematically assess and counsel women and children. The decision to work through ASHA as the channel for delivering the mobile content to clients strongly influenced the project's content development process. Behavior change messages and protocols for assessment, treatment, and referral of pregnancy, newborn, and postpartum complications have been developed to align as closely as possible with the government's ASHA guidelines and existing training content. The ReMiND project has thus far gone through 2 major content development processes. The first and longest was focused on content for the project's pregnancy application. We began with an existing pregnancy checklist that Dimagi had developed in collaboration with World Vision in Afghanistan. From the basic framework provided by that checklist, content was revised using the government's ASHA training modules to ensure that the assessment of the woman's pregnancy-related behaviors and practices, as well as key counseling messages, fully aligned with government guidance for ASHA pregnancy home visits. The field testing process for the pregnancy application included initial work with 10 pilot ASHA and local health authorities to help validate content and refine translations. Extensive observations of ASHA's use of the mobile application with clients were complemented with periodic interviews or focus group discussions with ASHA and with clients to get their feedback on content and successive revisions. A similar process is currently being followed for field testing postpartum application content. The postpartum app is much larger and more complex than the pregnancy application and was developed from scratch rather from an existing checklist. However, lessons learned from the pregnancy application development process about content formulation and how to maximize field testing are allowing the postpartum content to be developed in less time. Examples of major modifications or additions that have resulted through field testing mobile content with ASHAs and clients include shifting from close-ended to open-ended questions. The mobile application was intended to be a conversation starter between ASHA and their clients, but the initial use of close-ended questions to gauge client knowledge and behavior was actually a conversation stopper. Modifying the audio content to prompt more open-ended responses has helped to move the ASHA and her clients toward more interactive engagement during home visit counseling. Another modification came from early observation of the first versions of the pregnancy application, which quickly identified that it took too much time to go through all of the mobile content, and that too much counseling content was trying to be covered in a single visit. To address these challenges, the content focused on assessing and tracking the pregnant woman's service utilization and behaviors was separated from the counseling content. So now the pregnancy application has two separate tools, one that is a checklist of behaviors and the other that is a counseling tool. The counseling tool within the pregnancy application was modified into separate topics. Rather than trying to cover a full range of pregnancy-related counseling topics during each home visit, the ASHA can now choose from a list of available topics. Logic is built into the application that adjusts the list of available counseling topics based on the woman's trimester of pregnancy or the number of days postpartum. The challenge of illiteracy among the ASHAs themselves led to further modification of the application to include audio content and labels to help facilitate the ASHA's navigation through the application. And a final content modification is around planning ahead for the wantedness of girls. Sex-selective abortion of girls is increasing in India. In Kaushambi district, there are only 859 girls born for every 1,000 boys born. Early content included generic messages about the value of the girl child, but the project's concern about more strategically targeting these messages led to secondary data review and primary research around this question. As a result, the application content has been modified to help identify pregnancies that fit the profile of high risk for sex-selective abortions. Work is currently ongoing to refine behavior change communication messages for women and families who fit this profile. Finally, some lessons and recommendations. Test, 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 and then scale. Plan sufficient time for field testing and application revision before scaling to a large number of users. Once an application is scaled up, it's much more challenging to introduce changes given the time and financial costs of reinstalling or retraining users. Another lesson is that it takes a team. Content development requires sectoral, technology, translation, and implementation expertise. Take this into consideration and plan accordingly when developing mobile content for clients. The lure of real-time data can lead you to include lots of nice-to-know content in your mobile tool or application. This can lead to user fatigue due to loss of interest because the content is too long or complicated. It can even lead to fraudulent data entry. It also puts program managers or others at risk of not actually using all of the data that's generated through the mobile platform. Where mobile content includes data collection, focus only on the need-to-know information and begin planning for how and when that data will be used at the time you're developing the content. And finally, be willing to share. You and others will learn much more that way. The sheer volume of mHealth work currently happening means that there is a lot of potential for learning. So share what you learn and learn from what others share. If you'd like further information about the ReMiND pilot project or CRS's other health programming in India, please feel free to contact me at the email at the bottom of your screen. Thank you.